The honor of introducing Dr. George Prendergast, who is the CEO of the Lankenau Institute for Medical Research, former editor-in-chief of Cancer Research, and Dr. Len Appleman, who's a professor at the University of Pittsburgh and is running the clinical trial, part of the phase 2 trial. And feel free to ask questions at the end. All right. George, take it away.
Thank you, Chuck. It's a pleasure today to give you a 30,000-foot overview of the exciting SYNC-T approach to metastatic cancer. Can I have the next slide, please? Conflicts, disclaimer. Okay, and we're off. So,
George, go to your shoulder, separate.
All right, I need a, there we go. Okay, now we're caught up. So this approach you're going to hear about today in some detail really builds as a third level on the advances of immunotherapy in cancer. So I think many of us in this room would probably agree now that the breakthroughs in this field really derive from the idea that cancer is a disease of immune insufficiency, initially locally and then systemically. During the long battle that a cancer cell nest has with the local microenvironment, there has to be an outcome that either leads to control, to progressive disease, to eradication. The so-called immunoediting model of cancer, I think, is very compelling from my chair. And in thinking about how immunotherapy has made advances, of course, initially it was to relieve the immunosuppression in the locale of a tumor or tumors so that you could achieve an awakening and a re-engagement of the immune system in doing its normal job of fighting rogue cells, in this case, genetically plastic cancer cells. And the transition from our thinking about killing tumor cells with chemotherapy or targeted therapy to immunotherapy was, of course, pioneered by the work on Yervoy and Keytruda and other like molecules that really changed the game. Now the problem here, as everyone in this room is well aware, is not everyone responds when you treat the immune system. And sometimes you see some rather difficult side effects, autoimmune side effects, which medical oncologists have learned to control. But a barrier in the field has been higher order immunotherapy to get a state in which the patient can benefit from multiple mechanisms of attack. And this is where the field has been stuck now for several years. Despite having multi-targets, there's been a huge effort to try and perform combination immunotherapy with 3 or more agents, and that is where the field has gotten stuck, partly because we are still married to a systemic approach to immunotherapy. The serious toxicities and the high discontinuation rates, for example, in prostate cancer patients are a barrier in that field that we're starting with the focus. And this is one of the things that SYNC-T therapy gets around. The ability to treat locoregionally, not systemically, to get over the immune toxicity with lower doses, but still achieving high effective doses in the locale of a tumor. The clinical activity of the first iteration of this concept, which I've referred to as cryoimmune vaccination, is something that SYNC-T does specially. And by getting around the autoimmune toxic problem, opens a break into which science can now flow. So as you know, prostate cancer is a cold tumor. Low expression of PD-1, minimal T-cell infiltration, low mutational burden, and an immunosuppressive tumor microenvironment. In this particular disease, objective responses are quite low. There's been a huge amount of effort to try and boost this by combination therapy with anti-PD-1 and anti-CTLA-4, but the responses remain low and the toxicities go up. This is where the difficulty lies to a large extent in the field, which is how do we achieve what was achieved many years ago with traditional chemotherapy or more modern with targeted therapies where we need a combination of therapies to attack a cancer, which is plastic and heterogeneous. So SYNC-T therapy is revolutionary because it gets beyond that problem, but it also synchronizes the location of antigens, immune cell control, and a drug approach with multiple APIs. Same time in the same place within the body to motivate in the locale of a particular lesion the ability to fight. The approach being taken reveals novel T cell clones in patients, more numerous than we've seen with single or even dual immunotherapy, checkpoint therapy. The high effective dose can still be achieved by delivering local regionally that combination of drugs you would like to use, but with low systemic exposure. And this low systemic exposure is what allows you to get beyond the autoimmune toxicity that has been the barrier in the field. So what does SYNC-T look like in principle? In principle, it's the creation of anonymized but personalized antigen waves by freezing part of a tumor and releasing antigens that migrate to the lymph node and can be recognized when immediately following you deliver a multi-target biologic. In this case, in prostate cancer, 4 different drugs, all designed to get at the tumor, but by synchronizing the local antigen release with the local relief of immunosuppression, you can generate what turns out to be, with multiple cycles in a patient at different lesions in monthly cycles, a systemic T cell response. This is another key aspect to understand about the SYNC-T breakthrough, that not only does it get beyond the toxicity barrier from autoimmunity, but it also produces, despite a local regional therapy used in cycles at different lesions, an ability to awaken the immune system systemically. So a local regional approach can turn into a systemic therapy and do so rather effectively with large numbers of T cell clones that result from this approach. What are the mechanisms of action here? And in particular, I'd like to highlight the ability to go from local regional to systemic. In releasing antigens, thank you, Chuck. In releasing antigens as a result of the cryo-freezing portion of the therapy, you do so to create not only the antigen release, but an inflammation that's acute because of the cryostimulus. A huge inflammation, if you like. This releases not only protein antigens, but other kinds of structural antigens that may be unique to the cancer cell that we may not know, but does so in a way that's very personalized as to that lesion. Into the tumor microenvironment, those damps, the activators, if you like, of a strong inflammatory response, along with the antigens, then combines with the subsequent immediate injection of a multi-immunotherapy cocktail as a single drug injection. As a result of those 2 steps, you're getting relief of immunosuppression, you're getting a new strong exposure of antigens, tumor antigens, specific for that patient, into the locale that can inform the local lymph node environment and the microenvironment to begin to fight. 2 particular drugs, as you can see at section 3 here, are really designed to improve the antigen response at the level of antigen presentation. CpG, a DNA ligand that acts as an adjuvant, if you like, a pro-inflammatory adjuvant that adds to the inflammation you've already created with cryotherapy. And CD40 agonist, which many of you already know has had extensive study, as a way to tune up the ability of a dendritic cell and antigen presentation processes that are efficient by that cell, so that local T cells can be informed and educated to those antigens. And here I want to emphasize that because of the cryo approach and the use of the CpG, you're getting a rather generalized, strong inflammatory response, along with a wave of antigens that may not necessarily include just protein antigens, but also other antigens that could be unique as a result of epigenetic or metabolic processes that are unique to that lesion. As a result of those activation events for antigen presentation and the flood of a local lymph node environment with the specific antigens to that tumor, you begin to have the opportunity to prime and activate effector T cells. And here's where the anti-PD-1 and CTLA-4 comes in at levels that we understand very well to reduce exhaustion and to reduce broadly immunosuppression against the rogue cell foreign antigens, if you like, that every cancer presents. As a result of the local activation of the T cell proliferation that you could imagine would fight effectively locally, you also get a dispersal of that signal. And here's where I think there's a lot of science for us yet to learn. But it is clear that in the patients that receive a set of these cycles of treatment of SYNC-T, that you can see a relief of suppression in untreated lesions, and they begin to respond as well. Some of this is no doubt the fact that you've created now T cell armies that can migrate and look for their targets at other tumors. As a result of some of the work that you'll see from Dr. Link, Dr. Appleman, we know there's a huge number of T cell clones created in patients. In my institute, we're reproducing these observations in animals, and we're learning a great deal that's consistent with the idea that T cell clones and maybe other mechanisms are involved in the fight. So, for example, as Glenn Dranoff has historically argued, we ignore B cells. Are B cells involved here? Quite possibly. Are macrophages or monocytes involved here? Quite possibly. Some of the animal experiments we're doing are suggesting that we have an all-out attack that's happening, and that this is happening at the systemic level. So the science that advances here is going to fill in a lot of the gap between the two boxes you see, between the lymph node and the local tumor microenvironment, including those microenvironments where other tumors reside, and yet, while untreated, might still be attacked by a systemic response. At these levels also, PD-1 and CTLA-4 delivered locally seem to be key, but without any treatment at all, whether cryo or injection of immunotherapy, untreated lesions seem to be able to respond, as you'll see from the following speakers. So in thinking about the mechanisms of action, to me, the most exciting aspect is exploring how SYNC-T has managed to capture a local regional response that may be powerful by synchronizing antigens, the relief of immune suppression, and the time and place in which you're delivering these treatments to a systemic response after several cycles, as many patients show, as we can see in mice, where a single treatment will cure a mouse, not only to antigens that are presented by the original tumor, to which that mouse, if it's cured, will become resistant, but also to other tumors that we introduce into that animal that are genetically distinct. The huge number of T cell clones that are being generated here, I think, is a key to understanding why SYNC-T looks so exciting and represents a real new thrust for thinking about how local regional therapy can become a standard with these kinds of mechanisms of action. Now, I want to talk a little bit about the device that's used here. Many of you know about cryotherapy. Many of you know that it does have immunological effects and that surgeons use it widely today. What Syncromune has done is make it easier on the practicing surgeon. This is a hollow tube used as a cryotherapy device where the tip is frozen, and once placed by an interventional radiologist through image-guided assistance, it stays in place. You freeze, thaw, and then using the same device that stays in place, the needle that stays in place, you introduce your drug category. So everything's happening very quickly. As soon as those antigens are being released, within minutes, you're seeing multiple APIs, multiple immunotherapies being introduced into that tumor. This is a very easy way to approach cryotherapy. We've done cryotherapy in animals, which I can tell you is a bit challenging, because if you have to inject after you do a traditional cryotherapy, it's a bit challenging, and that would certainly be the case also in the clinic. But this is a key aspect to making this kind of therapy personal, anonymized antigen, but personalized based on the lesions that you're seeing, and making it easy, technically easy, for an experimentalist or a surgeon in the clinic to deliver the combination therapy here. To go into a little more detail, because I already mentioned these drugs, of which, in principle, you're already familiar with. The ones being used in SV102, the drug cocktail that's being injected after cryotherapy, these are proprietary agents that in some cases are similar to or maybe superior in binding affinity to the ones that we know very well, approved in clinic. These are all drugs that have already seen clinical trials on their own in therapeutic studies where the agent itself in phase 1 and phase 2 has already had a lot of characteristic use. Now again, the way these drugs are being used, local regionally, at low doses to the system, but at high doses to the tumor being treated, you can produce some powerful effects, which my colleagues will show you. So we have now an animation for you to see
The
the process.
SyncT solid tumor treatment platform is designed to work within the body to synchronize immune system education and stimulation using a multi-target drug and device combination therapy. SyncT is an investigational, novel, personalized cancer therapy that targets multiple mechanisms to empower the immune system to recognize and destroy cancer and to defend with immune memory.
This is an aspect that is also, I think, very intriguing,
CT,
the creation of memory
ultrasound imaging can
in the
be
local
used
regional
with
setting.
SyncT. SyncT can target both primary and metastatic tumors. Once our proprietary device is inserted into the target tumor, the first step is to lyse a small portion of the tumor. This causes tumor cells in the lytic zone to rupture, releasing neoantigens into the tumor microenvironment. Neoantigens are tumor proteins that can be used by antigen-presenting cells to educate T cells within the immune system.
Studies
and
suggest
empower
that
them
partial
to
lysis is
recognize
key.
and attack cancer throughout
Retaining
the body.
maybe some of the tumor and
The
leaving the
second step is
microenvironment
to
around the
infuse our
tumor
proprietary
is
multi-target
important
drug
to the
into
most
the lytic
efficacious
zone.
response. Still yet to be
The
studied.
multi-target drug
It
is
differs
designed to
from
reverse
traditional cryotherapy
immunosuppression
where
and be
full
highly
ablation, and even in the local
immunostimulatory.
microenvironment, a margin is desired.
Portions
That is
of
not
the
the case
mixture
here.
of drug
It's a
and
distinct feature of the
neoantigens
therapy.
flow out of the tumor via the lymphatic vessels into locoregional lymph nodes. This synchronizes the location of the three components necessary for T cell education, namely the patient-specific neoantigens, the multi-target drug, and the immune system components in the tumor microenvironment and tumor-draining lymph nodes. The goal is to activate the immune system and combat immune suppression, resulting in effective patient-specific T cell education. The third step is the expansion of anti-cancer specific T cells that can recognize and destroy the cancer throughout the body. In summary, SyncT is a novel, personalized cancer therapy platform that has the ability to target multiple mechanisms to empower the immune system to recognize and destroy cancer and to defend with immune memory.
The context of this in the history of cancer research is important. We're not a field of genetics and epigenetics anymore. We're not a field of metabolism anymore. We're a field that has to recognize that almost everything we know in cancer and drivers in the cancer cell are probably involved primarily in immune escape. So even though we know BRCA1 is a DNA repair enzyme, it drives immune escape. Even though we know RAS is a danger signaling molecule, it drives immune escape. Of course, all the molecules we've studied over the years in cancer cells have cell autonomous functions, but those are invisible if you haven't first selected for clones that escape immunity. So in pulling together the field and thinking about the future, we have to think much more about infection, where the body naturally controls thousands of infections at once in our body. The immune system can be thought of as therefore a useful tactic by analogy to control thousands of cancer cell clones, even given the plasticity and the heterogeneity that differ from lesion to lesion, where, as you'll see, complete responses are still possible from targeted treatment of a relatively small number of lesions in a patient's body. So with that, I'd like to hand off to Dr. Link, who will introduce the next phase of our presentation. John.
Thanks, sir. So the procedure itself is very easy for a urologist or interventional radiologist to do. Basically, every day of the week they do tumor biopsies and place a needle into a tumor, and they're very comfortable doing that. Most prostate cancer biopsies is done outpatient a lot of times, even without any anesthesia, except for local anesthesia. And so there's not like a new skill or something that's needed to be able to do SyncT technology. Very routine for urologists to treat a lesion in the prostate by putting a needle in it or putting multiple needles in it in a grid fashion to do biopsy. guided by transrectal ultrasound guidance. The same for interventional radiologists that are very comfortable coming in, doing a procedure and leaving. The procedure itself takes about 45 minutes or so to do. You place the needle. The freezing takes about 1 minute. You freeze about a 1 centimeter ice ball that creates about 50% lysis in that zone of freezing. About 10 minutes of passive thaw, and then the drug is infused over a 5-minute period, and then the needle's removed. So that's really as simple as it is from a clinician standpoint. A key inclusion criteria for this trial were histologically confirmed metastatic prostate cancer, previous treatment with one or more approved second-generation androgen inhibitors, and with or without prior chemotherapy. We also included in this trial patients who refused hormonal therapy, which turns out to be a significant portion of the prostate cancer population, surprisingly. They had measurable disease by RECIST 1.1, where there was soft tissue that could be used for the vaccine component of the therapy, and ability to give informed consent. It was the usual types of exclusion criteria. One cycle of therapy is treating a single tumor location in a patient every 4 weeks. So it can be the prostate, it can be a lymph node, it can be an exophytic soft tissue component that's rupturing out of a bone metastasis. And ideally, you can do different lesions on different cycles. Each one then lysing and releasing antigens from that particular metastatic site. The primary purpose of this trial was to evaluate safety. This is a first-in-human trial done in 15 patients. Secondary response, we looked at overall response rate, rPFS, and OS. We also did exploratory measurement of pharmacokinetics and some cytokine analysis and some T-cell analysis, which I'll show you in a moment. The patients were evaluated for response every 2 cycles by whatever the imaging technique that was used for the soft tissue, and typically either bone scan or PSMA PET scanning to look at the bone lesions. The baseline characteristics of the patients, it was a mixture of demographics. Median age was 61. Most of the patients had excellent ECOG performance status of 0 or 1. 13 out of the 15 patients had skeletal mets in addition to their recurrent disease. 100% then had prior androgen therapy or had refused it. 20% with prior chemotherapy, 33% had prior radiotherapy, 13% had prior immunotherapy. Here are the responses and the number of cycles it took to achieve the response. Partial response or complete response was observed in 87% of the patients. So overall response rate was 87%. 8 out of the 15 patients had complete responses. 2 patients had stable disease, so the disease control rate was 100%. PSA is interesting in that when you're doing a partial lysis of the tumor and doing needle placement, you're actually elevating the PSA when you do the procedure. And so the PSA tends to fluctuate during the months on the procedure, and then when you stop and wait 2 to 3 months, the PSA basically comes down nicely in essentially all the patients. To date, 3 subjects have died off study. We did conduct an independent radiology review of the results because this was determined by the 2 main investigators on the study in terms of response. And they converted 2 of the complete responders into partial responses on the basis of single bone mets that they thought were persistent. One of those actually was a persistent lesion that subsequently became a site of recurrent metastatic disease. But it was very congruent with the 87% response rate. This is a waterfall plot. And so you can see fairly dramatic responsiveness of all the soft tissue measurements. And to get a complete response, all the bone lesions had to resolve as well. I want to just mention like the patient that's second from the left that had about a 15% reduction in tumor volume. That patient was a patient who came in, got their first cycle, came in for their second cycle of therapy, got treated, started having leg weakness, and they had a cord compression that was occurring at a site of a pre-existing large spinal met. And the family actually took the patient off therapy because they were concerned. But, cord compressions, of course, happen in about 15% of prostate cancer patients during their course of disease. The patient subsequently got salvage Taxotere, had a fantastic response, and the PSA went to 0, actually, in the patient. But they already, after 1 month of therapy, had a 15% reduction in their soft tissue volume. But that counted as one of the 2 grade 3 adverse events that we saw in the trial. Now, the summary of the key results was 17.2 months median follow-up. Median time to response, 2.9 months, so basically 3 cycles of treatment. Median duration of response was at 12.1 months, and we reported this. RPFS was at 14.2 months, and overall survival had not been met at 17.2 months. We had 3 subjects that had died out of the total of 15 subjects. We're now out past a median of almost 24 months in the patients, and last I heard, I think there's only been 1 additional patient death, although we haven't done a really thorough systematic review of all that. But very encouraging that some of these responses are durable out to 2 years, and survival has been excellent in the trial. Mind you, it's a very small patient cohort. This is an example of a patient. This is actually a younger physician in his 50s who developed widely metastatic prostate cancer, failed hormonal therapy, and was progressing. His performance status is beginning to decline. He wasn't able to work anymore. We counted more than 50 skeletal metastases, you can see on the PET scan on the left-hand side of the slide, which included pelvic mass, a pelvic mass in his prostate and multiple enlarged lymph nodes in his pelvis. Was treated with 7 cycles of therapy. About 3 cycles in, started developing very severe bone pain that was actually at multiple different lesions in his body, and actually he wanted to quit the therapy, but we were really struck by the fact that the bone pain was throughout the body as opposed to 1 or 2 lesions like you typically would see in a prostate cancer patient when a bone is starting to fracture or having a problem with the disease advancing. And he remains in CR currently. I should mention none of these patients were mismatch repair deficient in this study that we evaluated. This is another patient that had a complete response, had multiple nodal masses, 7 or 8 nodal masses between 3 and 5 centimeters in size, in a prostatic mass, 2 bone mets in the skeletal spine. After 6 months, went into complete remission. Sorry, thanks, Eamon. And had done very well. This was an interesting patient who had a persistent lesion in the prostate. We treated them with about 7 cycles of therapy, and they had this persistent lesion in the prostate. They had a single bone met that resolved, and this prostate lesion was still hot. If you look at the scan, second from the left, you can see that in the prostate. So we kept treating the patient out to 12 cycles, and then we decided to biopsy that area. So we did biopsies of the site of this abnormality, and we found only normal prostate tissue and scar tissue. So they were just a pathologic complete response. Now, in terms of safety and tolerability, as George went over when he reviewed the prostate cancer data, when you do intravenous PD-1 and CTLA-4, you get 40 to 50% grade 3 and 4 autoimmune side effects, and some 40% of patients will drop out of therapy, which has been a real blockade to the large-scale phase 3 trials that have all failed thus far in prostate cancer with checkpoint blockade, with the exception of selecting mismatch repair deficient patients, which are only 2 or 3% of the population. 41 treatment emergent adverse events, 95% of them grade 1 or 2. There were only 2 grade 2 immune-related adverse events, a hypothyroidism and a hepatitis, both of which resolved and didn't delay getting additional therapy. There were 2 grade 3 adverse events not related to the therapy. One was the spinal cord compression I just told you about. The second was a patient who had problem voiding after the procedure, simply had a bladder catheter placed for a day, removed, the patient could void fine, and that was it in terms of toxicity. So as oncologists, we're used to thinking about patients where when a patient has autoimmunity, you give them intravenous checkpoint blockade therapy. That can be encouraging because there's a rough correlation between getting some autoimmune side effects and maybe a better response, clinical response in the patients. And we've always kind of assumed that those things were related to each other. I mean, this data suggests that this is true, and unrelated, meaning that you're showing the patient might have a strong immune system, but that shouldn't really be that one is predicting the other. And I'll show you some PK data here. And when we looked at pharmacokinetics, the red bars at the top are the single agent antibody API that's part of the SV102 drug. given as a phase 2 recommended dose. So that's and the pharmacokinetics show very nice high Cmax from that antibody. The blue bar is the dose that we used in the SV102 drug of that API, and we use about 10% of the systemic dose for the CTLA-4 and PD-1, about 30% for the CD40 agonist antibody, and that's in part because the CD40 has much lower intravenous concentrations because of toxicity. And if you look at the pharmacokinetics for the CTLA-4 and PD-1, it represents about 2%-ish of what an equivalent systemic dose would be. For the CD40, it's basically not measurable or barely at the level of detection. For the CpG oligonucleotide, not detectable in the peripheral blood. So you can think of the Sync-T therapy as reducing the systemic exposure by 98 to 99% reduction in systemic exposure. And so this argues that when you're seeing lower autoimmunity, perhaps it's the efficient intravenous distribution of the drug through the lungs that causes pneumonitis, through the liver that causes hepatitis, through the colon that causes colitis. And so it may be the resident cells in those organs that's responsible for the autoimmunity, independent of what you're doing local regionally. That's where I'm saying these two effects are separable from each other using the technology, which is really key, which means that it opens up the avenue. In the chemotherapy world, it's not a new concept to overcome resistance by using drugs with non-overlapping mechanisms to be effective. I'm older than some of the people in the room, and Vince DeVito was my chair at the National Cancer Institute when I was there. And overlapping, multi-agent chemotherapy and doing the mathematical calculations about how much tumor can resist, those same principles apply here. The problem with immune therapy has been when we try to push the limit there, we trigger systemic autoimmunity that can be very destructive to the patient. And so this approach in general, as a general approach in immuno-oncology, we believe could be very useful in putting different combinations together of what you're trying to defeat by having non-overlapping mechanisms. And you have two advantages there. One is that, the tumor is still very variant, but the targets for the immune therapy are often immune cells that are not having varying genomes and trying to escape. They have their fixed genomes in the T cells and the macrophages and that sort of stuff. So this idea of non-overlapping toxicity, but very low systemic exposure, we believe is an attractive fundamental concept over and beyond just the activity of the multi-component drug in terms of general principle. Now, when you look during the pharmacokinetic collection period at cytokines, you see very rapid increase in interferon gamma, TNF-alpha, IL-6, anti-tumor cytokines we're used to. During this time, especially the first few days after therapy, a number of the patients will have flu-like symptoms, low-grade fever, feeling fatigued, some nausea, occasional vomiting. And then that seems to resolve in a short period, and they do fine, basically, throughout the rest of the treatment period. Now, this is some data we're excited about. It's very early data, so we don't have a lot of detailed, we have path specimens out, but we don't have any tumor biopsies data to report out or spatial genomics or any of that sort of stuff. But when we looked at T cell clones and the expansion of T cell clones, what we saw in patients is, in the patients we measured this in, they got between 50 and 500 new T cell clones that were expanding. These were expanded TCR beta clones associated with known MHC-restricted tumor antigens in some cases, and they came out in waves. So after the first couple of cycles, you'd see some T cell clones. After 4 cycles, you'd see more clones. After 6 cycles, you'd see more clones. It's exciting to sort of see that the theory behind what we're doing locally to create the educated T cell is happening. We haven't done any analysis on NK activity or B cells or that sort of stuff. In the phase 2 trial, we're doing a lot of adjacent scientific analysis. It's actually fairly intensive in the trial. And Len is going to tell you about that in a second. Now, these are the limitations here. This is a small number of patients. It's only 15 patients. In these 15 patients, they all had, there he goes. They all had their prostate intact, so the tumors were in the prostate, and they weren't patients that had their prostate removed. And 5 out of the 15 patients were patients who had refused hormonal therapy. So they were upfront first-line therapy. In the 10 patients that were hormone refractory, 5 out of those 10 had complete responses. Out of the 5 patients that were de novo hormone-sensitive patients who had refused hormonal therapy, 3 out of 5 patients had complete responses. But it gives you the opportunity potentially to get to a complete response without prior hormonal therapy. In the phase 2 trial, the FDA wants us to get additional safety data before we treat any other patients who have refused hormonal therapy. So the phase 2 trial is strictly hormonal refractory patients, and that's sort of by FDA mandate. So in summary, a highly encouraging clinical activity to start in a small group of patients, no grade 3 or 4 autoimmune adverse events. Of course, again, it's a small safety data set here to start. We're really impressed by the really low systemic pharmacokinetic exposure in the patients and how that correlates with low toxicity. And that's the reason we've jumped into the phase 2 trial, which Dr. Appleman is going to tell you about right now. When you advance the slides, the arrows don't work. You have to use the page.
Well, thank you all for coming and for the invitation to speak. I'm going to talk a little bit about the design of the ongoing trial, which we're one of the sites for at the University of Pittsburgh. Sorry, I may not be advancing this the right.
Page down to the right.
Oh. So just as an overview, you heard about the study procedure, and in the ongoing trial, that treatment is delivered every month for a patient up to a total of 12 treatments. And as Dr. Link mentioned, it can be, if there's more than one site that are potentially targetable, it can rotate between the sites for each session, and there's only one lesion per session that's treated. It's done in the outpatient setting, either depending on the site with urology or interventional radiology. At our site, we're doing all the procedures in interventional radiology, where they have the involvement of anesthesia and the facilities, and the urologist and the interventional radiologist work together on the prostate cases. And you heard from Dr. Link a bit about the eligibility criteria. It's for, again, patients with castration-refractory metastatic prostate cancer who have had documented progression through at least one of the ARSIs, used often more, as you know now, as standard, starting with hormone-sensitive metastatic disease. Prior docetaxel chemotherapy and other treatments are allowed with a maximum of 3 lines of therapy for CRPC. And patients have to have, going back up to the first point, have to have measurable disease by RECIST to be eligible for the trial, and lesions that are amenable to the procedure. And so we review those with the study team before, as part of the screening process, to make sure that the lesions are accessible and have the right anatomy for the treatment. And in general, looking at the last point here, the patients are treated with conscious sedation for the procedure. Wonder why I pressed it, but here we go. As mentioned, it's up to 12 cycles of treatment. For baseline imaging, patients get standard axial, either CT or MRI imaging, Typically, patients have a PSMA PET as well. I believe that's going to become more mandatory with a coming amendment. And if patients have their prostate intact, they have a prostate MRI as part of the screening, usually a parametric study that can be used for mapping for the treatment. And those patients also have a prostate biopsy as part of the screening assessment to help with the mapping. And there's scans every 8 weeks, and then going out to every 12 weeks after they've completed study treatment. As you see, the endpoints are the usual, looking at safety with the dose escalation up, calculating the maximum tolerated dose and the recommended phase 2 dose, looking at the usual response endpoints, response, radiographic progression-free survival, overall survival, and then in addition to the pharmacokinetics, as Dr. Link mentioned, a number of correlative pharmacodynamic and other immunologic studies. And in terms of the design of the study, the study starts at cohort 1 is one dose level down from the dose used in the phase 1 study, escalating up to that dose, and then if tolerated up to one additional dose, and then going into an expansion of 52 subjects who will be randomized between 2 doses selected from part 1. And so just in terms of the logistics of conducting the study, it's really a multidisciplinary process, working with the urologist, especially in the cases where there's where there's a prostate lesion intact that's being treated, and the interventional radiologists, of course, are key, and then us from medical oncology, and working closely with the physicians from Syncromune who have a great experience from the phase 1 and earlier work in terms of assessing the lesions and helping to care for the patients while they're on study, managing the logistics of the procedure and the post-procedural care. And as I mentioned, there's CT and MRI for planning, and in terms of being large enough for the treatment, it has to be at least a centimeter in 2 different axes, and based upon the length of the cryo needle, it should be no deeper than 9 centimeters or so to be able to safely access it. And that's something, when we look at the scans before people go on, that we look at together with the team. And in general, our experience has been that it looks complicated here with all these different components to conduct the procedure. From our experience, it's been pretty painless in that there's a lot of support from the sponsor and from the companies that provide these different components. So it really was not, I was worried that it would be before we started, but it was not really a problem in terms of getting all the equipment together for the interventional radiologist and the urologist to use the equipment. We, in terms of doing the prostate treatments, we're renting a navigational biopsy machine that has integrated seamlessly with the cryo system and everything else. And so it's complicated, but our experience has been it's worked out well, and it haven't really hit any roadblocks. So as you heard from the other speakers about the immunology behind the procedure, it's a novel approach using the regional therapy, and really minimally invasive, similar to undergoing a CT guided biopsy or a diagnostic biopsy or a prostate biopsy. And in the phase 1, you heard about the toxicity profile looks favorable, and also you saw some of the images from the patients in the phase 1. It looks promising, and so we're excited to be part of the phase 2 study, and look forward to having some data to share with you all in the future. So thank you for listening.
So if you need more information about the study, slide should stay on. Did you? What happened? There we go. LEGION100trial.com. We're really interested in opening up additional clinical sites. We're in the process of opening up a total of 40 sites. We have 5 sites open, 13 in process to open. We're also interested in if there are patients that are in your clinics that you think might benefit, please call us so we can arrange a referral at one of the sites. I also wanted to acknowledge, in particular, the patients that have been part of this trial. And I want to mention in particular Dr. Jason Williams, who is really the pioneer of the Sync-T technology. He's an interventional radiologist who started putting all these various components together in his clinic in private practice, and seeing really important results across many different diseases besides just prostate cancer. So we think that there's already evidence that this is going to be a general principle that's going to evolve in the oncology landscape. Thank you so much. Any questions? For anybody here at the table?
Okay, I will just speak loud. So, thank you so much. This is really interesting, and I really hope that that will continue to work that smoothly. Have you checked your patients for any neuroendocrine involvement in your adenocarcinoma, and does this correlate with outcomes?
We're in the phase 2 trial. We're excluding patients with neuroendocrine disease if it's a component of the tumor. One of the patients that had a complete remission had a recurrence that was a neuroendocrine recurrence with widely metastatic new lesions in the liver after they had a really nice response. So, neuroendocrine evolution, of course, happens in 15 to 20% of tumors. In this 15 patients, we saw that happen in one of them.
Do you have any insight on why this is happening? Because neuroendocrine tumors should have a high tumor mutational burden, so they should also activate T-cell responses pretty firmly.
Yeah. The answer is we don't know why that is. Neuroendocrine tumors tend to be pretty resistant to checkpoint blockade, lots of other things. So time will tell, I guess.
Okay, thanks so much.
Thank you.
Hi, that was very interesting. I was wondering if you see true abscopal responses, especially in lesions that are, the lesions that are not treated, that are large, that might not have any exposure to anti-PD-1 or anti-CTLA-4 and have a really suppressive microenvironment. Do you see responses in those lesions?
Sure. So in the patient that had the 50 skeletal mets, the resolution of all 50 spots of tumor, none of those sites were treated. And the patient that had the nodal disease in the pelvis, I think one of the nodes was treated, and there were like 7 or 8 large nodes there, and all the other nodes responded, and they were between like 2 and 4 centimeters in size each. So you definitely see routinely abscopal effect with the therapy.
I had a few questions. Sure. Are you considering a prostate?
Do you say a few questions? We don't allow one question.
Oh, okay. Too bad. Oh, well. So the first of one is, do you consider a prostate lesion resist positive disease or not? In other words, can that be resist positive disease? Because prostate lesions are not technically often not considered resist.
Yeah, so we measure them. We measure them by MRI, and we find you can successfully do that.
Okay.
And track them.
And then, have you biopsied any of these tumors that you're actually doing?
Yes, we have pre and post biopsies on a few of the patients, but we don't have any of that data back yet.
Okay. So, in other words, I guess the next question is: are you looking at the antigens from those biopsies, or at least the predicted antigens from those biopsies, and looking to see if any of those hundreds and hundreds of T cell clones that you're actually seeing pop up are specific to the tumor, or if they're
yeah, so Adaptive Technologies, that's the company that's superb at doing this TCR analysis, has a library of a lot of targets that they've identified by researches that various people have done in their library. And we've identified 20 or 30 of those that are tumor-specific antigens, but not necessarily prostate-specific antigens thus far.
Okay. And the last
we haven't put out any of that data yet.
And the last question is, would you consider doing just something like PD-1 maintenance afterwards, which is comparatively
I think it's an excellent
non-toxic
thought. Dr. Williams, I know in his clinic, has sometimes done PD-1 maintenance in patients to try to prevent T-cell exhaustion. We haven't incorporated it into the phase 2 trial right now, but it's certainly something to consider. I would say that if I had a patient that had a significant response in the phase 2, and then they were recurring, I think it would be very, very rational to give them single agent PD-1 and see what happens to them if they already showed that they had evidence of responding. So it's a good suggestion. And that was 3 questions, I believe. Yeah, go ahead.
Hey, I had a question about skin cancers, because your technology kind of would lend itself for these early stage skin cancers potentially, and that could be an untapped territory. We are trying to get somebody to give us like PD-1 for local injections into tumors, and we couldn't find anything.
I think this can be approached for any tumor anywhere in the future. I don't know. It's going to, right now we know 75 to 80% of patients don't benefit from checkpoint blockade. And that seems to be primarily because of the biology of the tumors, more so than anything else. And we don't fully understand all of those reasons why some tumors are so resistant. That means there's 80%, 75 to 80% of the patients that you have a chance to do something new with. We know a significant number of those tumors, for instance, are HLA negative and other sorts of problems in terms of T-cell specific therapies. But this really is sort of a kitchen sink approach, right? You're hitting basically all the major pathways of immune suppression. And so I think we're going to find an admixture that's going to vary from patient to patient about which is the most important components as we learn more. But there's a huge black box. So we really want to collaborate with academic colleagues. Akash is here from University of Chicago. We're going to be collaborating with him in his core facility on a lot of the prostate cancer work and some others, and try to understand a lot of this. But I think skin tumors are a super important area of refractory treatment that this could be helpful. Of course, we have interest in trying to move this forward earlier when you can. And so we're already in discussions about an earlier stage prostate cancer trial once we have a larger patient data set to make the FDA happier with this initial data that we have. But we're an infant that's just sort of getting up and kind of wobbling around walking, and we're trying to get to the point we're jogging. We're not sprinting yet. And it's hard to start new therapies, especially it's a multi-component drug, so there's 4 different APIs to manufacture. There's a device, a super simple device, just a smart needle, but it's still a device. And so it's a more complex regulatory environment that we're tackling here. But, based on Dr. Williams' work, it was clear we get off the shore and start thinking outside the box about putting more things together sooner rather than later, as opposed to waiting for an experiment where you'd add 1 drug and then a second drug and then a third drug and then a 4th drug and take 18 years to do the trial. So we're trying to, change. I don't know, George, if you have a sense of.
Yeah, since we can now model in mice the SYNC-T therapy, we've begun to vary the components along the lines that Dr. Williams has done clinically in his case studies. And we have identified some that are, very attractive to think about as, future directions. I've termed this cryoimmune vaccination just because I think SYNC-T is the first clinical iteration of what could be general principles of using tools that we already have on the table, and often a lot of clinical data, but in the different setting of local regional to systemic conversion therapy, if you like.
Yes.
Hi, I'm Mike Gentile from Merck, and we've met
Mike,
several
good to see you.
times. Good to see you too. So I'm about to ask a couple of questions, or I'll combine them into one.
Good.
That I should know because I've already pounded your door down several times. Did you do longitudinal PSA and ctDNA? I understand PSA is going to go through the roof in the beginning, but over time.
So we have blood samples to look at ctDNA, but I don't have any of the data yet. The PSA, yeah, we did longitudinally, and what you see is like we had a patient like the PSA started at 15, and then it went to 25, and then it went to 20, and then it went to 18, and then it went to 15,
Right.
and then they stopped, and 3 months later the PSA was like less than 1.
Right.
So when you're on the active treatment, and people know this from prostate biopsies, that the PSA can sort of be perturbed for like a month, sometimes even more
yeah.
after the procedure. So, med-oncs are used to thinking about PSA as like being the absolute marker to follow for response. And when you're doing these active procedure with the partial cryolysis, you really can't use that as reliably as an active response. Now, the couple of patients that did poorly that had the stable disease for the first portion, I think 2 and 4 months each or something like that, then their PSA started really going up rapidly. There clearly was signs of progression with that.
Right.
But when it kind of rattles around the baseline, we think that's all procedure related.
So I just one comment. I mean, you say you had the ctDNA. I mean, it would be really cool to see baseline and longitudinal ctDNA, not just for levels, but to identify drivers and see how the drivers are changing over time.
Yeah.
That could be huge.
Yeah.
And understanding progression. But
Well, we'll send some samples to Merck, and they can run them and send us
All
the
right.
data back. That would save us a little bit of pocket change.
Hey guys, first congrats on all the sites that are currently launched. That's exciting. In terms of, first question is related to biomarker strategy because I didn't see on there. I assume you're doing standard TLS characterization and stuff with biopsies. Are they doing biopsies throughout, like every time they go in
We're going
and
to do
one of these
biopsies
12s?
throughout, actually.
Yeah, so they'll have biopsies going throughout like that. And then when an interventional radiologist such as myself or urologist injects, they're always injecting in the setting of the trial the same volume for this 1 centimeter ablation zone.
Yeah,
Is that
so
correct?
it's a fixed volume of 15 mils
Right.
that we give every time. So
So it's the same as a phase
we're-
1 in that
yeah,
setting.
we're giving a volume that's larger than the 1 centimeter where
Right.
we create a little potential space.
Mhm.
But that's purposely done, so you have to really put in your mind that unlike a lot of therapy you've heard about where they're talking about intratumoral, this is intratumoral, but we push the antigens in the drug through the tumor into the regional lymphatic. So it's local regional therapy. And as you know, a lot of prostate cancers don't have a lot of immune cells in the first cycle of treatment because there's not much inflammation. We think that's going to change. When we look at our biopsy data, we're going to see inflammation induced by both the freezing effect and by the drug effect and by starting to get your T cells to come into the prostate. Obviously, that must happen when those prostatic lesions respond.
Yeah, the only reason I ask is because I'm imagining, I mean, I don't know what happened with the patient who had spinal, whatever, whether it was treated close to the spine, but it would seem to me that
No,
kind
they
of-
weren't. They were actually treated in the prostate.
somewhere else.
when they
Okay.
had that lesion.
Okay, so and maybe that was just progression. But
Yeah.
but the question is like when it does limit the targets that you can go for because you're talking about diffusing CPG into an area that may be, for example, I don't know, if you're going in the pancreas or whatever, it may be functional tissue in some other way, right?
Yes.
Because it's such a high volume.
Yes.
I understand when you're doing it prostate only that strategy, but I'm thinking as an interventional radiologist, like all the other
Well,
sites that I would like to be giving this that may be limited
falls
by
under
the 15 mLs.
Yeah, this falls into the category is that you have to start somewhere. And, combining Dr. Williams' clinical experience and the way we basically design something that's easy and reproducible for the clinician to do every time. I think there's going to be evolution of this. What's the right cycle length? Is 4 weeks the right cycle length? Should it be 3 weeks? Should it be 6 weeks? Should the volumes change based on the tumor? if you're going into a small lesion in the skin that you're trying to treat, obviously it'd be difficult to put 15 mils into a lesion in the skin. So I think that's going to evolve over time. But we tried to start with what we thought when we designed this and chose the doses and everything else, like what's over home plate in terms of the key elements that you put together to do an experiment, to get an initial result to see if it has promise or not. Much to learn.
Cool.
Sorry.
Hi, Ruchin Chen from Mayo Clinic, Florida. Really, congratulations for very good outcome, and I think mechanism-wise also
Well, we appreciate
makes
Mayo
sense.
Clinic working their way towards opening all 3 sites for us. So we're actually working
Thank
with
you.
Mayo Clinic. But you guys aren't open yet, but you're in process right now.
When is going to open?
You tell me. the sooner the better.
Looking forward for this to open.
Yeah.
Just question, I think when you just ablated just partially of the tumor.
Yes.
I know some of the patients that even the biopsy, they will concern about the the metastasis of the disease, and what is kind of the chance for.
You mean a chance that the biopsy or that the ablation will
Because
induce
it's only
metastasis?
partial.
Yeah, so it's purposely only partial. For instance, we only need antigen release. We're not trying to ablate the tumor, so it's not an ablation procedure. We use the term partial tumor lysis or partial cryolysis to specifically say, in that 1 centimeter ice ball that we create, if you look in some of the other studies we've done, probably only 50% of the cells or so will die in that region and lyse, and the other part won't die. So they'll be temporarily frozen, but the cells won't die. So it's not ablation. We're not trying to ablate and kill the tumor with the freezing. We're simply trying to do antigen release. So much simpler. And when people do ablation, they'll often do a margin of normal tissue around it. And we don't want to be doing freezing and trying to stimulate more immunity against the normal tissue that you would do if you did a rind of tissue around an ablation.
I think that's a really important point to emphasize. The cryotherapy here is not therapy. It's a vaccination. It's a vaccination that comes with an acute inflammation as an adjuvant. It's then accelerated by the injection of the cocktail of drugs.
So it's kind of on-site vaccination.
Yes.
Okay.
It's an anonymized, personalized vaccination. So you can go through and find the antigens, sequence them, make RNAs, inject a vaccine, or you can do a partial cryolysis.
It's interesting, the whole vaccine concept.
And just one closing idea here is, I don't think we're just talking here about protein antigens, okay, which you don't reach with, say, the Moderna approach, where you're actually characterizing antigens. There's many antigens that are presented in tumor cells that are foreign that are not necessarily proteinaceous. So this is another very interesting aspect of this, which is with regard to the idea of cryotherapy as vaccination.
Well, the vast majority of off-the-shelf vaccines have failed because if you take one vaccine or one protein and you go across a group of patients, only a small number might respond to that. We've been at that for 20 years. I've been in cancer vaccinology for a long time, and that simply hasn't worked. In this case, when you look at the effect of the Moderna vaccines, for instance, which show really nice data with a personalized vaccine, it's very important that it's your antigen. That's that patient's antigen. I remember going to one of Steve Rosenberg's presentations, and I was working on a whole cell vaccine that we were giving to to all patients. And he went through some TIL cell data, 100 sequential patients. There wasn't a single antigen that was the same in any of the patients, and 97 out of 100 were passenger antigens. So the antigens are going to be patient-specific, and this is really the key to provide that antigen to be patient-specific. Yes?
Hi, Meadow Green, Bristol Myers Squibb. Earlier in the presentation, you mentioned that you can lyse multiple sites, right? Tumor types, locations, et cetera. What's the relationship between doing that multiple site administration versus just targeting one? Because you obviously had a complete
So I
response.
have a total data set of 15 patients.
Yeah, okay.
So ask me at the end of the phase 2, and I might have a better idea. Just try to get an idea of that.
Okay. And then my second question is just barriers to adoption in the community, because I think one of your discussants mentioned they had to rent a biopsy machine. There's literally a kind of device component here. What does that look like to you in terms of, I mean, it's a multi-component.
Well, we come out of our founders, Eamon Hobbs, who's my co-founder here, came out of the device world before he spent his whole career in drug-device combinations. So it is an important component of it. This device is very simple. The new device that we've designed, if you look at cryolysis equipment, it's like an airplane, dashboard kind of thing. It'll be a single push-button device. So you just hit the button, does the partial cryolysis. You don't move the needle. There's a pump behind it that pumps the drug right in immediately after that thaws. And the whole thing, soup to nuts, 45 minutes. If you talk to the interventional radiologists and the urologists we've been working with, they're super enthusiastic about this, about getting involved with these patients. And it's sort of a whole new way that they can treat their patients.
I'm
So,
just thinking about the upfront overhead of buying a new machine kind of thing. So, okay.
as you know, being from Bristol Myers, the cost of the machines or the disposable relative to the cost of the drug is minuscule in comparison. I don't say minuscule, but very minor component.
Understood. Thanks.
Yeah. Thanks, everybody.